I became a maternal health advocate when I became a mom 8 years ago. After delivering my first child, I experienced a complication that claims the lives of thousands of girls and women who do not have the access to care that I had that day. Once I learned about the global statistics related to maternal mortality, I felt compelled to use my voice and resources to do all I could to prevent these senseless deaths. Though the numbers have come down since then, hundreds of thousands of girls and women continue to die each year from complications caused by pregnancy and childbirth. That's someone who loses her life every 90 seconds. And for every one who dies in childbirth, 20 more will suffer lifelong debilitations. Pregnancy is the #1 cause of death in women aged 15 to 19 in the developing world, simply because their bodies are not ready for parenthood. It has been estimated that as many as 215 million women who would like to delay or avoid pregnancy can't because they don't have access to modern contraceptives. While progress has indeed been made, of all the Millennium Development Goals, MDG 5, to improve maternal health and reduce maternal mortality by 3/4, still remains the most off track. The cost of scaling up skilled birth attendants and health system strengthening for the world's poorest countries is expected to reach $5.5 billion in 2015. Yet by not investing in those areas, the economic and social cost of maternal and newborn mortality is $15 billion per year in lost productivity. It seems clear to me that we cannot afford not to invest. The statistics are indeed sobering, but to me, this issue is more than numbers. After traveling the world, meeting other mothers, and the health workers committed to ensuring safer deliveries, I decided to make a documentary film called No Woman, No Cry, in an effort to capture some of the stories behind these statistics. I traveled to Tanzania, Bangladesh, Guatemala, as well as the United States, with a small film crew to examine the barriers that too many girls and women face in accessing critical care throughout their pregnancies. In Tanzania, we looked at the human resource shortages that plague much of sub-Saharan Africa. In Bangladesh, we looked at the social and cultural barriers that keep women from seeking care, even in emergencies. In Guatemala, we saw women risking their lives to avoid unwanted pregnancies. And in the US, we learned that too many women, 1 in 5 of reproductive age, in fact, do not have health insurance during their pregnancies, leaving them vulnerable and without prenatal care. In every one of these countries, transport was an enormous barrier, and one that Every Mother Counts, the organization that I founded in 2010, continues to focus on in our advocacy efforts. In addition, Every Mother Counts focuses on several areas that represent the greatest risks to a mother's health: prenatal care, access to quality care, emergency services, improving postpartum care, strengthening systems and policies, and family planning. We know what many of the solutions are, and we know the dramatic differences they can make. We just need to take these solutions to scale more often in more places to reach more women. I congratulate GBCHealth on devoting a session specifically to maternal health for the first time at its annual conference this year. The private sector can and should be a major factor in driving change. The panel you are about to hear, Milestone Moments on the Path to Healthier Motherhood, will demonstrate ways in which forward-thinking companies have become a significant force for transformation in this arena. I invite all of you to explore the role that you and your organization can play in tackling this challenge. Collectively, we can make this a priority once and for all. I now have the pleasure of introducing to you the moderator of this panel. Aside from being a longtime ally in the fight against HIV, Gary Cohen is one of the most highly respected and influential corporate leaders in the battle to improve women's health and rights. In addition to his day job as Executive Vice President at BD, he is a tirelessly passionate advocate for keeping girls and young women healthy and safe. His expertise, energy, and personal commitment have made him a leading light in the advancing in the status of women and girls. He is also the newest member of GBCHealth Boards of Directors. Please join me in welcoming Mr. Gary Cohen.
can I ask the panelists to come to the stage as well? I'll introduce them in a moment. So thank you, Christy, for such kind remarks, and good morning, everyone. It's a pleasure to see you again today. A clergyman recently told me that women are more godlike than men because women create life through childbirth. Now, I'll let you draw your own judgment. It's a statement that I happen to agree with because there is nothing more important or precious than the regeneration of our population and the creation of life. So isn't it an irony then that this fundamental and fundamentally precious capability of creating life also represents the one Millennium Development Goal where there's been the least progress, maternal mortality, and virtually no progress at all in sub-Saharan Africa? As Christy mentioned, more than 350,000 girls and women die every year from pregnancy or childbirth-related causes. That's approximately 1,000 per day. And 99% of these deaths occur in the developing world. Can't go much higher than 99%, 1% higher, and it's everything. The lifetime risk of maternal death in industrialized regions, if you live in an industrialized country, most of you, not all of you do, is 1 in 4,300. So if you're a woman, you have a 1 in 4,300 chance of dying from maternal causes in an industrialized country. In sub-Saharan Africa, the lifetime risk is 1 in 31, which reflects a devastating disparity. Note that a moment ago I said girls and women. I didn't just say women. A lot of time you'll hear about women dying in childbirth. But we learned yesterday, and repeated again by Christy today, that maternal mortality is the #1 cause of death among young women and girls 15 to 19 years of age. And I think you probably know that a girl who becomes pregnant under the age of 15 has a 5 times more likely chance of dying in childbirth, which has to cause us to ask the question, what is causing girls pre-15 or even 15, 16, 17, 18, what's causing them to become pregnant? Child marriage, sexual exploitation. These underlying behavioral and social factors are continuing to drive some of the most intractable public health issues and human rights issues in the world. Now, fortunately, there's also positive news here. There's an unstoppable momentum occurring now, and I think we've seen this happen before. And this momentum is to address the health needs of women and girls, including maternal mortality. Just in the last several years, the UN Secretary General launched Every Woman, Every Child. The Clinton Global Initiative established special focus on the health needs of women and girls. The GBC, as you know, launched Healthy Women, Healthy Economies. The World Health Organization recently launched the Partnership for Maternal, Newborn, and Child Health. And even Archbishop Desmond Tutu is placing specific personal focus on child marriage. So Ban Ki-moon, Bill Clinton, Hillary Clinton, Margaret Chan, Desmond Tutu, they're onto something. They figured out that in addition to the human rights implications, the basic human decency implications, that addressing the health protection and education needs of girls and women is the secret to solving the world's most intractable problems. I personally believe this as well. If we address the health, protection, and education needs of girls and women, we will solve the world's most intractable problems. They aren't the only ones who figured this out, though. We have 4 fantastic panelists today who will each speak about a specific set of interventions that they've been involved with and their organizations have been involved with to improve maternal health and reduce maternal mortality. And if you want to solve some of the world's most intractable problems, address the health, protection, and education needs of women and girls. We've seen this type of momentum building before, early in the last decade around HIV/AIDS. We know the tremendous accomplishments that have been achieved, largely also through the connection with the business community through GBCHealth. We've seen it building for malaria around 3 years ago with tremendous gains. That's now what's happening on this issue. So I would say if you want to get involved, if your organization wants to get involved, now's really the time. So let me now move to introduce our panelists. So first, Sarah Brown is the global patron of the White Ribbon Alliance for Safer Motherhood and president of Piggy Bank Kids and CEO of the Office of Gordon and Sarah Brown. Rhonda Zygocki is executive vice president of policy and planning for the Chevron Corporation. Dr. Naveen Rao is the lead of Merck & Company's Merck for Mothers initiative and chair of the maternal health pillar of the MDG Health Alliance. And Dr. Benjamin Schwartz is the senior director for health at Care USA. And it's a pleasure to have you join us this morning, and I think we're going to have a fantastic discussion with our panel. So let me join you. We're going to speak about specific topics that are relevant to the overall area of maternal health, starting with girls' education. We know that keeping girls in school saves lives and transforms society. Madeleine Albright did a study a number of years ago that showed that societies that keep their girls in school experience substantially faster GDP growth. And education is the #1 factor influencing when women get married and start families, with increased levels of education being linked to delaying first births among teenagers until they're at a healthier age. So we know that adolescents and teenage girls face a much higher risk of maternal mortality. And Sarah, some progress has been made overall in maternal death rates, not so much in sub-Saharan Africa, but in Asia and other parts of the world. But almost no progress has been made in reducing these deaths among adolescent girls. Why is this, and what role can education play?
Thanks, Gary. Having been involved with the maternal mortality campaign over a number of years, we've seen those numbers moving. I mean, there were decades before where people on the ground were recognizing the maternal health issue, but it took a while for that to reach the top end and to come down through. What we've seen in just the last 5 years is a huge shift in the political will in the system to address head-on the issue of maternal mortality. And it's making, as you say, dramatic improvements. So from figures of over 500,000 deaths every year, it's down to somewhere around the 350,000 mark. And possibly with the latest numbers coming through showing that it's even a little bit lower than that. But within those figures, there's been no change at all for saving the lives of teenage girls. And we know they're at greater risk. As you said, it's 5 times more likely if you're a young teenage girl of dying in pregnancy and childbirth, and the leading cause of deaths of teenage girls in the developing world. So this is something we have to address. When you look at all the different medical interventions, Naveen will speak to this, but it's not rocket science, with all due respect. Most of those interventions are well known, and broadly speaking, relatively low cost to some of the other ways of addressing big, health interventions like HIV/AIDS or malaria. Digging deeper, when you dig deeper at what it is that's not saving the lives of these girls, not being married would be a really good start, age 13, 14. But so too, if you're a carer for younger children and out with other adults that you don't know, if you're out working and again you're in contact with other adults, there are lots of situations where young girls are very vulnerable, not just when they're married. The solution across the board is having them at school. If a girl's at school, she's safer. If a girl's at school, her status changes in her own household as she's learning. She's got the opportunity for a school lunch. She's got an opportunity to get her vaccinations. She has an opportunity to learn about her own health and well-being. So I've been working very closely with John Teestrom this past year and looking to create a separate GBC for education, a Global Business Coalition for Education, and to work with a lot of those businesses who want to look at that interaction between health and education. When you're working as a business, you're approaching things for the benefit of the entire community where you're working. So you're not necessarily going to divide everything into health and education as neatly as the professionals and the people in international institutions too. So the very simple answer, I've given a longer answer, but the very simple answer for teenage girls to help reduce their vulnerability through pregnancy and childbirth is to have them in school.
So let me just ask a follow-up question to that. Because there's an interrelationship between, if you keep a girl in school, she's less likely to experience conditions that may make her become pregnant. Mm-hmm. But if she experiences sexual violence, for example, rape, sexual exploitation, mm-hmm. a relative or someone in the community taking advantage of a girl at a very vulnerable point in their lives, that makes them more likely to have to drop out of school. Mm-hmm. Girls who experience sexual violence are 3 times more likely to experience a teenage pregnancy. They're 5 times more likely to die in childbirth, as we know. They're more likely to contract HIV/AIDS. They're more likely to experience chronic conditions. In this interrelationship, I'm just interested whether you think there's a way also of creating protective mechanisms in society to keep girls in school so that some act of sexual violence isn't what causes them to have to drop out of school in the first place.
Yeah, this is an issue for the developed world, not just the developing world, across the board. there's always things that you can do within the context of a school environment, and all of it also needs to be in conversation and in communication with parents, caregivers, and the wider community. And we know that anywhere, you know, in the United States as much as it's going to be true in sub-Saharan Africa. So there is a role for schools to play in that, although there's also a burden of care and responsibility on teachers, where you've got to get the balance right for how much you're putting onto their shoulders. Interesting, looking at the issue of the children who are not in school at all around the world, you have 67 million boys and girls, slightly more girls than boys. And if you look at where they are, 50% of those children are in just 6 countries. So you have India, Pakistan, Nigeria, Afghanistan, Ethiopia, Nigeria. Did I cover that right? Yeah. But at the other end, you have 28 million out of that total 67 million are children whose lives have been displaced because of conflict. And that's when they're at their most vulnerable to all kinds of violence, including sexual violence. So there's quite a strong initiative at the moment to look at creating some sort of education without borders that's modelled on a Médecins Sans Frontières or Red Cross model, that's able to go in and provide education. And that education isn't just going to be about literacy and numeracy. It also has to be about working with children who are going into education where their young lives have already seen an awful lot of trauma and upheaval. So that has to be part of the care that you're giving and the education you're bringing.
So let me pick up on a word that you mentioned, and I'm going to use that as an opportunity now to segue over to Rhonda, and that's the word vulnerability. This issue of teenage pregnancy is associated with when girls become particularly vulnerable. Likewise, you know, we're going to speak with Rhonda about prevention of mother-to-child transmission, and I remember very vividly in the last decade when HIV/AIDS was transitioning from a disease that was most associated with certain populations, men who have sex with men, commercial sex workers, intravenous drug users, in the early days of the pandemic, and then transitioned into heterosexual couples who were sexually active, and then transitioned into married couples, and then ultimately transitioned into newborn babies, the most vulnerable population. And it's insidious how disease finds its way to vulnerability. Now, Chevron has been very, very active in this area, which I know is widely appreciated. And it's critical for these interventions to start early on, and they have to be sustained and enhanced as a woman enters impending motherhood. So there's a number of different important health issues that can be addressed if women are effectively brought into the healthcare system during pregnancy. And the interventions such as targeting HIV testing and providing PMTCT are a key means not only of preventing the transmission to a newborn, but also improving women's health overall during that very vulnerable period. So I'm going to turn to you now, Rhonda. What has been Chevron's approach in using its business assets to influence PMTCT outcomes?
Well, thanks, Gary. Well, I think the most important business asset is our employees themselves. And so our effort in this whole area around HIV/AIDS, including PMTCT, is to protect the health of our employees. And just to set some context, we're a multinational energy business. We do business all over the world, but some of our biggest operations are in areas that are heavily inflicted by this epidemic and other diseases. And so the health of our employees is critical to our business. When you look at business assets, I'm going to talk very kind of at a high level. You know, it starts with our values of protecting people, the environment, our values of valuing diversity are very integral to how we approach HIV/AIDS programs in the company. And it also starts, if you're going to solve a problem that's a business problem, it's not a program, it's a policy. So our AIDS policy in the company provides employees with first, freedom from any discrimination, access to treatment for them and their dependents, family members, as long as they're employees, and education and outreach and counseling. So as a business, we're a bunch of engineers, and we build big things, and they have to be operated by skilled people. So we took a systems approach in terms of looking at HIV/AIDS and PMTCT. And that means it starts with 4 things in our program. Heavy emphasis on education, getting at the stigma, understanding the misconceptions, providing training to our employees, getting them to understand the disease itself, heavy on education. Then establishing a culture to encourage testing and treatment. You've got to get your employees to want to seek this information and know for themselves. Third, addressing stigma and cultural norms. If we can't get over those barriers, we will never get to the point of people being treated and treated for life. And then fourth is access to comprehensive care. And we made a commitment as a company on all 4 of those levels, and it takes all 4 of those levels to make it work. And once you start down a road, you cannot step back. And so our commitment through policy is everlasting. And so employees know that when they step up for counseling, for testing, for treatment, which is all confidential, the company will be behind them for as long as they're employees. When we look at PMTCT, it's just part of a subset of the whole AIDS arena we have. And with respect to caring for mothers, when you look at that system, confidentiality is a huge, huge issue. We provide one-on-one counseling. Our medical employees go into the homes. They don't have to come to the clinics. We make sure they have their drugs. We're with them at birth to provide treatment to the mother and the baby. We follow up. And we use our employees, talking about business assets, to create the trust, which is a huge, big barrier when you start this kind of endeavor. We had to train our employees to become peer educators and counselors to our other employees, because that's where the trust was. They weren't necessarily trusting our medical professionals at the onset. So our employees were assets to help other employees. And then you use your community assets, your business partners. In one of our countries, we outreach to the local nuns, and we provide them with a vehicle to go around and make sure the mothers have the formula and their drugs, because they trust that. So finding trust in the community, where are your partners and your trusted assets, using your employees, and using a systems approach that you have all the pieces really has made it a success for us. And just to finish off, and Christy mentioned Milestone Moments, and we've been at this over 10 years, and a milestone moment for us to know that the system can work is for 7 years in Angola, and for 11 years in Nigeria, amongst our employees and their families, no mother-to-child transmission. So with the systems approach, it can really work, but it takes a collection of assets and a long-term commitment to get those results.
Rhonda, that's a remarkable statistic, and it has to breed a lot of confidence that this can be brought down literally to zero transmissions. Let me ask you one quick follow-up question. Chevron's an energy company. It's not a health company.
That's right.
And somehow you had to go through a process of convincing people who decide to invest these funds to pursue so much of a health outcome. And also, Chevron is much more broadly involved in HIV/AIDS in general. So let me ask you that, but also from a personal standpoint, if you can relay any personal experience that you've had leading and working on these programs as a very senior business person, leader in Chevron, any personal experience that you've had with this?
Well, first of all, from an energy company involved in this, it is about where you have operations, billions of dollars of investments that have to be operated safely and reliably with trained and skilled employees. And if that workforce is not healthy, you are not going to have that business outcome. So it is a business issue. So it's very easy to get on board with this is the health issue, to create a safe and skilled workforce for the long term. We don't invest in a country for 2 years. We invest for 50 years. And that trained and skilled workforce has to be able to operate those assets responsibly. So the business case is very clear to us. Personally for me, it is about really engaging with our medical teams in countries, some of whom are here today. Our Angola team is here, who have done all the wonderful work. Very proud of them. To see how serious they take this issue, the commitment to do everything from educate to remove stigma, to keep harping on our employees to do the right thing, is what's most inspiring about this whole endeavor for the company. That when the corporation gives the go-ahead and puts the policy and resources behind it, how serious our country people take it up, because it's their colleagues, their families, their communities, and that's what inspires me at the corporate level, to keep supporting such a noble cause.
That's great. So one thing I think this example from Chevron demonstrates, and I think it's often, you can generalize this, that it's not so much what needs to be done. That's often fairly clear, what interventions work. It's how you get it done. It's taking things that could be very straightforward and applying them in very complex, resource-impoverished settings. So Naveen, I'm going to turn to you. Most of the maternal deaths are occurring during and immediately after labor and delivery. And we know that 90% of these deaths are avoidable. They're preventable. So what's causing them to continue to occur?
Thank you, Gary, and appreciate the opportunity. Before I lead off, just wanted to put things in perspective. There's one thing that each one of us in this room has, and probably the only thing that I can guarantee each one of us has is a mother. What I'd like you to do is maybe even for 5 seconds, think of your own mother. What she meant to you and where would you have been without her? Really, it is an irony, and as Gary said, you know, the one thing that we value the most is the one thing we put up into the most jeopardy and stand by while these mothers are dying. In fact, if you live in sub-Saharan Africa or in South Asia, the most dangerous day of a woman's life is the 24 hours around the childbirth. And as Sarah said, it is not rocket science. We know what is killing them, and we know why they're dying. And so as I relate those 4 big killers and 3 big delays, it would be wonderful if each of you could just think, filter it through your company and through what you do for a living in the business side, and see how can you bring any of this and which piece of this appeals to you. And there's enough of us that are around. We can talk to you later if you're interested to go into any more depth. But basically, there are 4 big killers, and we know what's killing them. The first one is postpartum hemorrhage. This is when the woman bleeds after delivering the child. Very easily treatable. A shot of oxytocin or 2 tablets of misoprostol can be life-saving, but very often this is not available to the woman when she needs it, where she needs it, at a price she can afford. Second biggest killer is preeclampsia. This is when the blood pressure shoots up, damages the kidney, heart, convulsions, the brain, mother dies, child dies. Again, when it reaches the eclampsia stage, magnesium sulfate, known to treat it and prevent death, again, not available. Third biggest killer is infection. Very easily preventable through hygiene and skilled birth attendants in a clean environment. Fourth is obstructed labor. This is the one that when the girl needs cesarean section. So we know what's killing them. But why are they dying? And to come to your question, Gary, they're dying basically because what was called in the maternal mortality literature, the 3 delays. Very simply, there's a delay in seeking care, there's a delay in getting to care, and there's a delay in receiving care. Let me just explain those briefly again. If you can filter this through, what does your company do for a living and where can you engage? The first thing is seeking care. Very often, it's not the woman in these huts who can decide that she wants to go to a facility to deliver. It's a complex cultural, economic decision that has to be made. I can relate a story. When I was in one of the huts in India, I was told that the elder in the family was debating whether to send his daughter-in-law to a facility, and we knew she needed a cesarean section. When I talked to him, it was a hard choice. I mean, he basically was able to tell me that he has a limited amount of money, and he has a hard choice whether to send his daughter-in-law for the C-section or whether to buy seed for next year's planting. In this instance, I'm glad to say he decided to send the daughter-in-law, probably found other ways to get money for seed. But these are the kind of stories that decides on the delay to seeking care. First of all, to understand that childbirth is in most instances normal, but when things go bad, that is when you need facility care, and you really don't know when and who will turn bad. So the first instance is seeking care, the delay in seeking care. So imagine that they've decided to seek care. Second delay is getting to care. Very often in these parts of the world, there are neither roads nor ambulances. I have actually seen girls walk 8 hours, 7 hours in labor pain And for, as a man, I'm ashamed, I don't know what it is, and I will probably, will never know. But for all the women who've been through a childbirth knows what it is. And imagine at that stage in your life, you have to walk 7 to 8 miles to get to a facility. There's no transportation. They've not put away money for transportation. At the last minute when they need transportation, it's not available. Again, I'm asking you to filter this through what does your company do? Is there any place you can play? So the second delay is getting to care. And the third delay is receiving care. So here she has made it all the way. She's come to this facility, and the cupboard is bare, and there are no physicians, there are no doctors, there's no anesthesiologist, there is no health care, there's no provider. And so the third delay is in receiving care. Again, very often, simple things that can be done, exactly as Gary mentioned, it's how you implement it. But it's all about, is there any way to get the healthcare training that's necessary? Is there any way to get the commodities into the cupboards? Is there any way to hold accountability and ensure that these women's lives are saved? So it is an irony. We know what is killing them. We know why they're dying, and we're standing by and watching it.
So let me relay a personal experience. My first trip to sub-Saharan Africa many moons ago was in Mali. I spent about 2 weeks there and visited a small clinic in a very rural area, and a woman had just given birth there. What she was provided for delivery was a mattress without a sheet sitting on a steel frame and a small steel bowl and a very dirty rag. That was all. Fortunately, she gave birth successfully. With so many of these births occurring either in a home setting or in a clinic such as that, I have to relay quickly a second experience in Kisumu, Kenya. Also, a woman had just given birth, and I've traveled maybe 25 times to sub-Saharan Africa in the last decade, and I don't go out handing out money, but if a woman just gave birth, I can't help myself. I hide some money in my palm of my hand, I shake her hand, and a little bit of money for the baby. So there's a boy named Gary running around Kenya someplace. I'm sure he's the only one, because she was such gratitude. But in a circumstance such as that, how do we address these fundamental gaps where either the reach to a clinic, as you mentioned, is difficult, or in the home setting? Have there been any interventions in your experience that have been helpful in those settings?
Absolutely, yes. I see this glass is half full. I appreciate you telling that story. But even though she was on a mattress, and just springs, no mattress, steel bowl, she was 100 times luckier than millions of women who don't even have that. So as harsh as it may sound, and plus, of course, when she got a little from you, that just put her in a completely different league for survival, both for her and for her child. But really, if you look at it, let me just talk briefly about the innovations that are happening in all the three delays. Number one, if you look at the delay in seeking care, there is one of the biggest innovation that's happened that's being touted as a success is the ASHA program in India. They have 800,000 community healthcare workers who have an incentive to take this pregnant woman to a facility to deliver. So she gets $20, the woman gets a sari, they get a delivery. Almost facility deliveries in India have gone up 200% because of this. So there are ways to incentivize to be able to get the woman to seek care. The second delay, if you were to look at innovative ways in which people have gotten over the delay in getting to care, TransAid and organizations such as that have got creative ways of getting local taxi unions to decide on a call basis that one of them will transport these mothers when they need it. There's a way that the community pays these taxi services to be on retainer, so to speak. And this can get so creative. Let me give you one small example of how creative it can be. In Nigeria, they realized that it's not just giving the person the money to be on call to take these women to the delivery rooms when they need, but as a payback, they let this person be number one in the taxi line at the airport, because that is the big fare. So something simple like that, which costs nobody anything. Person feels good, he gets a badge, he's allowed to go first in line to pick up the people from the airport. So there are ways, innovative ways we can think of it. That is the second delay. And the third delay, when we talk about how we can get commodities, so if the woman can't come to the facility and over 40% of all of them deliver at home, can we get some commodities to them to hold? in a sustainable business manner. For example, there is what we call the Mama Kit in Uganda that is being sold to these mothers by mothers who had deliveries and had a good experience. It's a small amount. In the kit is gloves, a razor blade, a plastic mat, some cotton, sanitary pads, simple stuff in a bag that even if the woman was to go to the facility, we teach her to take this with you because these don't exist in the facility. And if she's delivering at home, she has that. So there are innovative ways. It's just a question of saying enough is enough. It's enough to say that I guess we need to decide that women are worth saving, our mothers are worth saving, and then it's amazing how many things open up.
Thank you, Naveen. And you mentioned the role of community health workers and also the success in India. It's interesting. India has the most privatized health system in the world. 70% of healthcare is delivered through private sources. So it indicates that even in a circumstance like that, where there's less reliance on government, real progress can be made. You also talked about the critical role of health workers. And Ben, let me use that as a transition to ask you, because CARE has had extensive experience in equipping health workers across the motherhood life cycle, and particularly also focusing on the postpartum period as well as the birthing period. In what ways have you seen frontline health workers impact postpartum health outcomes?
Well, let me begin with a story. About a month ago, I traveled to Bihar, which is the poorest state in India, in the northeastern part of the country, and went to a primary health center in West Champaran, right up against the border with Nepal. We arrived there at about 1:30, and a woman had delivered at 10:30 that morning and already had left the facility. And this is very common in India as well as in other places where women will stay a very, very short time in the facility after delivery. We've collected data from observing women during labor, delivery, and the immediate postpartum period in health facilities, and have found that of 90 women who are observed, none of them had a check before they left the facility and counseling that they would need in order to identify complications that could be life-threatening for themselves or for their infant. Because of this, the World Health Organization recommends that 3 postpartum follow-up visits be done during the week after delivery. And most of the time, those visits need to occur at home because women are not going to come back to the facility during the first week of life. Yet again, looking at the situation in Bihar as well as in many other countries, we found that only 12% of women received those postpartum visits, when most of the mortality to mothers and obviously all of the mortality to their newborns occurs. In order to address this in Bihar, we're working with funding from the Bill and Melinda Gates Foundation and implementing a number of innovative approaches that help strengthen the continuum between healthcare in the community and healthcare in the facility. Some of these interventions include giving incentives to healthcare worker teams, where the teams include both facility and community-based workers so that they can better communicate and better integrate the care that they provide. We're equipping the ASHAs with mobile phones that have algorithms and protocols to guide them through how to most effectively do a postpartum check for mothers and infants, to recognize complications and to be able to refer women back to the facility for the care that they need. And we're also working with public and private sector partnership to strengthen the ability of the system to provide family planning to women postpartum so that they can better space their deliveries and increase the chance of survival, again, both for the mother as well as the newborn. Another quick story. We were pilot testing the mobile phone-based algorithms and protocols, and this was just as we were developing the system. And we were working with about 10 of the ASHAs in Bihar to test. And one of the ASHAs had gone out and done this postpartum check, and as she went through the algorithm, she noticed that the infant had an umbilical infection. and was able to refer that infant for therapy. And this was probably, in this massive program, the very first infant whose life we saved. And so it really emphasizes the power of some of the new technologies, some of the new tools that can be used to capacitate frontline community-based healthcare workers to better fulfill their functions.
It's fantastic. CARE does such phenomenal work around the world in this respect. I'm going to open up now to the full panel. I'm going to throw a few questions out. I'm going to give you the option. Answer anyone you feel like answering. And I'm not going to direct you to anyone specifically. And even if you're interested in just reacting to each other's comments, please feel free to do so. One is, if you could remove one key barrier to healthier motherhood, what would that be? Second question, what causes the light bulb to go off? You know, something that seems as obvious as putting global focus and attention and funding and momentum behind taking care of mothers when they're pregnant so that they can remain alive and they can give birth to a healthy child seems so logical, seems so important. Why hasn't it been acted upon more? And when you've seen the light bulb go off, what sets that light bulb off? And the third is, what impact of societal norms? What is it that's happening in society that's causing this to have not received the priority attention that some other issues have received? So whichever of those, anyone who wants to pick up on any of those questions.
I'll take the first question, which was, one thing you could change, I believe, or what the barriers. After all these years, stigma and social norms are still some of the biggest barriers. With all of the access to treatment, counseling, education, for mothers, it is still very hard in some of these countries to be, faced with the reality that they are HIV positive, to be able to disclose that to their families, to be able to take the right treatment during birth, and the issue of breastfeeding with the baby. And if there's any way in these kind of cultures that you could break down the stigma associated with that, the cultural pressures and norms of family life and the expectations, I think we could save a lot more lives a lot more quickly and take a lot of pressure off women who have to face all of that burden with their own HIV situation and that of trying to protect their children, where family expectations are a lot different.
I just want to mention one thing, and then Ben, did you notice yesterday when Lelene was speaking, when she said, I'm an HIV positive woman and I gave birth to an HIV negative baby? Did you see her face when she said that? Did you see how much pride and joy was expressed? That's not the first time I've seen that. I don't think there's anything more joyous that I've seen than a woman who's burdened with HIV/AIDS, probably through no fault of her own, and she gives birth to a healthy child. And that's really the reward, right, the return.
And then these women need a lot more role models and examples that it's okay to do just that. And the more we get that and a critical mass, the more ripple effect hopefully will go through these countries to allow the system, resources in place to kind of grab more and have better results.
If you didn't catch that yesterday, watch the tape. GBC will give you the tape. It's worth seeing. Ben.
I'd like to pick up a little bit on what Rhonda mentioned about social norms. And one of the things that we found in our work is that inequitable gender and social norms are a major factor that limits the ability of women to access the care or the preventive services that they most need. There's a belief that changing social norms is very difficult to do, and that it's somehow something that we in the West are imposing our values on other people. But I'd like to emphasize that it's not that way at all. What CARE has developed is a program called Social Analysis and Action. And what it does is it gets people to surface the social norms that really are generally unconscious below the surface. So in India, again, for example, women generally eat last, and there's no thinking about this. It's just the way it is. Or there's a preference for having sons, and again, no particular thought behind it, but it's just the cultural norm. And so by getting families to explore these cultural, these gender, these social norms, and to ask, is this what is optimal for us? Is this optimal for my family, for my community? It really begins to lead to transformation. In a 2-year program where we used a number of different tools to explore norms, we found significant differences in the mobility of women, in women who discuss family planning and family size with their husbands, and in maternal health behaviors. So when you talk about what are the greatest barriers, to me, the barriers are not necessarily within the healthcare system, but they are some of these gender and social inequities that we actually can succeed in changing.
Absolutely. And the question I wanted to answer was about the light bulb. And I wanted to give an example from Merck. I feel the light bulb goes off when you make a commitment, and then when you put yourself out there, how many people show up on a quest like this. And in 1 year that we have gone out and launched Merck for Mothers, which is our commitment at Merck to decrease MDG 5, it is amazing how many friends, well-wishers, partners, donors, NGOs, academics have shown up and saying, we will carry some of the burden with you. So I really feel the light bulb actually goes off when you see how many people are out there waiting for you to make that commitment.
I think I'm actually seeing light bulbs going off here as I'm sitting. You can't see it because you're all looking up this way.
Hopefully they're going on.
Pardon?
Hopefully they're going on.
Yeah, going on and staying on. Sure.
If I can pick up on the light bulb moment, there was a big question mark over why the focus had always, the Millennium Development Goal was set to have a target to reduce maternal mortality, and yet there had been no progress for so long. And it still is the case that maternal mortality has far less of an investment in it than any of the child health programs. I think that's where it comes from, that the obvious starting point, if you're looking at development opportunities, if you're looking at your own corporate engagement, is to be very child-focused. And there's a huge sense to that. There's not just the moral obligation to a new generation, but the truth about saving the lives of mothers is that is also the only way you will save the lives of all of those children too. When you look at the way the health MDGs have progressed, they were moving and then seemed to get stuck, particularly around the issues around newborn survival, some of the malaria targets, some of the other HIV targets. Where you don't save the life of the mother, the impact on her immediate family, on her community is really profound. The other thing is, remember when Naveen was talking, saying that the interventions are to go in and prevent infection by having high levels of hygiene, to prevent preeclampsia with just simple magnesium sulfate, to prevent postpartum hemorrhage with oxytocin. The cost of these drugs, magnesium sulfate is what, 3, 4, 5 cents at the most? Oxytocin, 30, 40 cents? Job done. HIV AIDS, when someone contracts AIDS, there's a lifetime course for them, a lifetime of treatment. If you go in there and have the right intervention with a skilled health worker who's able to administer the right intervention at that time, job done, life saved, that woman then has her life, her baby's life, and the contribution she makes to her family and her community. And that's what I think has been the real light bulb moment for a lot of people, is it's been the key that's unlocked the access into helping all the other MDGs too.
And so, I'm just going to have one quick comment. One of the biggest misnomers is that these are women's issues. If there's one thing we should dispel right up front, is that these are women's issues, that the health of expecting mothers, the health of a newborn baby is a woman's issue. You know, many times when I've been in circumstances such as this, talking about issues of sexual violence against girls or otherwise, I'm in an audience that's 90% women. And I sit back thinking, okay, men need to be in these conversations because these are global issues. These are the things that are holding the world's most difficult problems, both human rights injustices, financial problems, public health problems. These are the things that are holding them in place. So it's another element, I think, of the light bulb, is for people to recognize if we treat these as women's issues, that means half of the world's population is going to say, okay, somebody else take care of it.
Look at how good we are. In my country, in the UK, we're not that great at raising children when they're on their own, when they're in the care, when they're not able to live with their mother. I think that's probably the case in the US as well. You know, where the mother is there, everything can flow so much more readily.
Yeah, the role of women in society, we're not going to have to go on about that, but I think it's well understood that when a woman is removed from the society, nothing but bad outcomes happen. So So Naveen, Naveen was looking to get it.
No, I just wanted to add on what Sarah is saying on a much lighter note. She's absolutely right. We all heard it on a flight we've taken where the announcement says, put the mask on yourself before you put it on your child. Yeah. It's basically, even the airline says that if you're not there, your child has no chance. So put the mask on yourself first, which is basically what Sarah is saying is save the mother, the child will be also saved.
One piece of work that Naveen and I are working on, we're working with Imperial College in London who are convening because we have the Olympics coming to London this summer. It also means we have a host of VIPs descending on the city, which is a great opportunity to capture a lot of them to pay attention to other issues. So Imperial College is working with the British Foreign Office to convene a conference, but we've all been engaged in a working group for maternal health led by the next president of FIGO, and looking at exactly what the sort of optimal interventions are and to try and come up with more straightforward, more easily accessible formats for people to be able to get to grips with.
And just building on that, Sarah, I mean, the big light bulb moment in the whole advancement in age is the utility of ARVs in terms of the prevention in the long run. So it's becoming, it's not just for mothers and children, but for the whole epidemic. So you're getting to a very efficient solutions for all, and the more that becomes the norm and accepted, I think that's going to be quite significant to get rid of social norms and stigma that are associated with the women issues.
So Naveen, I have to say that I'm an extensive traveler like many of us. I've been to over 60 countries, and I've never had that moment when the masks pop down, and I'm going to be the person holding his breath to see what people actually do. Were they doing it themselves, or are they giving it to their kids first? Because I think, hopefully we won't have that experience. So Ben, and then we're going to turn to the audience.
Yeah, let me also speak to the importance of prevention, and particularly of family planning, because one of the things that Christy brought up in her opening remarks was that there are over 200 million women around the world who would like to use family planning and don't have the opportunity to do so. It's estimated that about 33%, 1/3 of maternal deaths could be prevented with appropriate voluntary family planning to meet this unmet need. A large portion of that is family planning to better space out births, which means using long-acting contraceptive methods. Often these methods are not available, or healthcare providers don't have the expertise to use them. But the biggest problem in family planning, again, takes us back to the community. It takes us back to the relationship between husbands and wives and mothers-in-law, the social norms, the preferences for boys. And so I think as we think about the issue, not only in preventing maternal deaths once they become pregnant, but also using family planning to meet that unmet need and to prevent those pregnancies that are not wanted.